Hello and welcome to another episode of the SITREP. Today we are talking about an intimate topic, which is erectile dysfunction. And today we are joined by none other than Dr. Rachel Greenberg. Thank you so much for being here today.
Thanks for having me. I'm excited to be here.
And so let's just jump right into it. What exactly is erectile dysfunction?
So the definition of erectile dysfunction does vary across different professional organizations. But in general, the way I think about it is erectile dysfunction is the inability to attain or maintain an erection that is satisfactory for sexual performance. And you can see within that definition, there is some subjectivity, right? One man's view on how long their erection lasts, if it's enough for intercourse, may be very different from another person's. For some men, having an erection that lasts for 5 minutes is great. For some men, inadequate, right? So there is some subjectivity to it, and that is really important in the definition.
And so what are some of the signs and symptoms? You've already alluded to a couple of them, but generally speaking, from what you've seen, what are the signs and symptoms of erectile dysfunction?
That's an interesting way to phrase it. So it's pretty obvious, right? When a man starts experiencing any changes to their erection, that can be erectile dysfunction. For some men, that might be they used to get morning erections every morning, right? And over time, with age, that they start noticing that their morning erections decline. For some men, it means that they used to get 10 out of 10 rigidity that was enough for penetration, and now it's 8 out of 10 rigidity. For some men, they used to last for 5, 10, 20 minutes, and now that time has shortened. So those are sort of all the possibilities of or the signs or the symptoms that how erectile dysfunction can manifest.
And is this something that's like naturally occur? Like even if I'm healthy as a horse, as I get older, it's something that I might experience, or is it actually no, throughout your entire life, it shouldn't really affect you?
It definitely can. Even in really, really healthy people, age is one of the most significant risk factors for developing changes in the erection. So certainly, especially men over the age of 50 or 60 should expect that there will be some decline in their erections over time.
Okay. And so what are some of the major, I imagine there must be a dozen or more reasons as to why someone might have erectile dysfunction. But what are some of the most common reasons that might be occurring? Yeah.
So in order to answer that question, I think it's important to kind of understand how erections work in general, because then we can kind of touch on like what then causes the dysfunction related to erections. So I think the number one thing is psychologic input, right? You have to be in the right mood. You have to have the sexual stimulus, whether that's being with a partner, who turns you on, for lack of a better phrase, whether that's watching visual stimulus in the form of videos or pictures. You really have to have that psychological input. And I think that's something that a lot of people overlook, right? Maybe when you were younger, you could have an erection at the drop of a hat, but as life progresses, as you get older, that may change. And so things that, used to be really stimulating to a person may not be anymore. Changes in your relationship, right? If you have any gripe with your partner, if things aren't going very well, then that person's probably not going to be turning you on in that moment. And so the psychological input is really important. Once the brain sends a message to the penis, essentially, you get neurotransmitters released via nerves to the blood vessels that are in the penis. So you need intact nervous function to have an erection. And for example, things like diabetes can affect the peripheral nerves. Things like patients who have had spinal cord injuries can definitely have impacts on their erection. Even men after radical prostatectomy for prostate cancer, that's one of the most common populations we see, especially amongst veterans. They almost always will have some degree of erectile dysfunction after that surgery. Once the nerves are released, they act on blood vessels that are in the penis, and the blood vessels kind of expand with blood. And that's what an erection is. It's just blood filling the penis. And so the blood vessels have to be able to respond appropriately in order to kind of relax and fill with blood. And the blood vessels have to have some degree of elasticity or like stretch, if that makes sense. So any process that affects the health of the blood vessels can impact the penis's ability to fill with blood. So hypertension, cardiovascular disease, high cholesterol, you get plaque buildup in the blood vessels, they're not going to expand with blood in the same way. And that is a huge risk factor, and one that a lot of people don't even know that they have, is like high blood pressure, even mildly elevated high blood pressure. You can see impacts on erectile function. And then finally, hormones are important in getting an erection. Specifically for men, that's testosterone. And so men with low testosterone, either related to age or some underlying pathological process, can definitely see an impact on their erections.
Is low testosterone like one of the largest factors that plays a role in this, or is it a lot of other things actually?
It's less important than the other things.
Really?
Yeah. And I think about testosterone, it's almost more important in like sex drive and desire, and like being in the mood to have sex. It can impact orgasm and ejaculation as well. But we have evidence to show that even in men with, symptomatically low testosterone, and we define that as a total testosterone of less than 300 per the American Urologic Association. In men who have low T, less than 300, even if you replace their testosterone, the changes on their questionnaires, we have like a validated questionnaire called the International Index of Erectile Function, or IIEF. I'll reference that a little bit. The changes in those scores, even when you correct this testosterone, are pretty minimal. It's like a 2-point increase out of, this goes up to 30 is the questionnaire. So it is an important factor. And I definitely send every man who presents to me with new onset erectile dysfunction, regardless of their age, particularly in younger men, I send them for to have their testosterone checked. And there is some benefit to replacing it, certainly for like overall sexual experience. But I wouldn't say it is the most important factor with regards to erectile function.
I would have thought that would have been like at the top of the list.
It is the one that patients like most ask about, because I think you hear a lot of stuff out there.
There's a lot of commercials and what have you on the radio and all. Yeah. What about drugs? I mean, does like using marijuana, or are there certain prescription drugs that it's going to cause erectile dysfunction, or it may lead to it?
Yeah. Unfortunately, many drugs can lead to erectile dysfunction. So recreational drugs for sure. Alcohol and cigarettes or tobacco use are basically the two substances that I feel probably affect erectile function the most, specifically tobacco use. So when anyone comes to me with erectile function, I always ask them, like, are you smoking? And it's a hard habit to quit, but it probably would have the most impact on recovery of erectile function. Alcohol also not only affects erections, but libido, testosterone levels. It can have huge impacts in that. And then marijuana use has been linked more so to orgasmic function. So men, in studies about men who use marijuana more like daily, like chronic marijuana users, they may report delayed orgasm or even premature orgasm. There is some link to erectile function, but I think the relationship is more about sort of overall sexual function with marijuana. With prescription medications, unfortunately, almost like every medication can cause erectile function. It doesn't mean it will, but a lot of cardiac medications like beta blockers, antihypertensive medications can lead to changes in erectile function. A lot of psychiatric medications like SSRIs, or things like Prozac, right? Antidepressants, anti-anxiety medications have been linked strongly to erectile function. And so, it's just important to have those discussions with your provider or their provider. Like if a guy comes to me and they're on metoprolol, a beta blocker, it's a hugely important drug for either they have atrial fibrillation or they have high blood pressure that they're on these medications for. And like, obviously you don't want to stop those important medications, but there's definitely conversations to be had with those other prescribers, like the cardiologist or the primary care doctor, that maybe this patient can be on an alternative medication that doesn't have as much of an impact on erectile function. And those do exist.
It seems like the two would be combating each other. Like if we're used like Viagra, but you're also on something to drop your blood pressure, it's like total opposites of. So
Viagra, they actually can do the same thing. The Viagra, we'll talk a little bit more about this general, this general class of medications called phosphodiesterase inhibitors. So that's Viagra, Cialis, Stendra. They dilate the blood vessels, and so they also can drop your blood pressure. So it actually is really important to consider if you're on other agents that can lower your blood pressure, like an antihypertensive, like some of the prostate medications we use, like Flomax to help people urinate better if they have enlarged prostates. We generally tell them to be careful with those other medications because if you take them all at the same time, you can see a significant drop in the blood pressure.
Interesting. I know that you kind of brought this up already, especially with the frame of mind that you're in when you're trying to have an erection. But how much does mental health play into it? I mean, I could be, my heart's fine, my blood vessels are fine, and this and that or everything else. I mean, how much of a factor is stress or depression, stuff like that?
It's huge. I'd say most men who come to me with ED have some degree of depression, anxiety, insomnia, PTSD. These can play a huge impact on a patient's erectile function. And then you kind of touched on this a little bit, but also the medications used to treat those things can be hugely associated with erectile dysfunction and poor libido or low libido, sex drive, things like that. One of the biggest side effects of SSRIs are low libido, weight gain. People just aren't in the mood. And so, it can play a huge role. And one huge thing with erectile dysfunction specifically is performance anxiety. So that's a huge psychologic detriment to erectile function. And it can just, I see 20, 25-year-old guys who one time they didn't get an erection for whatever reason. Maybe they weren't feeling well. Maybe they weren't in the mood, right? And then all of a sudden, next time they have sex, they're thinking, am I going to get an erection this time? Oh my God, is it going to happen again? And then it's sort of a self-perpetuating cycle. So I do see that a lot. And that's another psychological input that's important.
Seems like kind of like a double whammy that you've got the mental health thing going on, whatever it may be, depression, sadness, whatever. But then you're also taking medication on top of that.
Yeah.
And so it's a lot to overcome.
And I think another important point there is the impact that sexual counseling can have. So there are, psychologists who are specifically trained to talk about, sexual health and sexual intercourse and working with patients, not by themselves and also with their partners if they want, to kind of think about the challenges they're facing when they're having sex, work through some strategies that they can use to get them through the sexual process, improve communication with partners. Maybe a man's perception of what makes their partner happy is different than what the patient's partner actually wants, right? Maybe to one partner, penetration is hugely important. To another partner, they like oral intercourse, right? So it's just opening those lines of communication with your partner. And people don't always want to do that themselves, but having a counselor or having a third party try to mediate those discussions can be really helpful.
Is erectile dysfunction a sign that something seriously wrong is going on in the body?
I think that's a really important question. And it can be is the answer. So it's really important, when you're experiencing that to go get checked out, whether that's with a urologist, doesn't necessarily have to be right off the bat, but even just checking in with your primary care doctor. If you don't have a primary care doctor, seeking out a primary care doctor is important. And that's because we consider erectile dysfunction what we call a sentinel event for cardiovascular disease. So we know that in men, particularly young men who present with ED under the age of 40 or so, they're 7 times more likely to have a cardiovascular event like a heart attack in their lifetime. So, and it's kind of what we talked about before. It's because most of the time there is some process related to the blood vessels or the vasculature or to the nerve supply to the penis. Those are really the two biggest categories that can affect erections. And so you may not know that your blood pressure is 180/90 until all of a sudden you're not getting erections. So it's really important as, the provider that you're presenting to should know that to ask you to do a set of vital signs, to ask you those basic screening questions, to refer you to specialty providers like a cardiologist if they need, or if a guy comes to me for erectile dysfunction, I'm a urologist. I can say your primary care doctor should evaluate you for those other things. And some urologists will even do like basic screening for diabetes or high cholesterol. It's not unheard of for us to just send those labs to just make sure that there's nothing else going on. The long and short of it is, don't panic. It doesn't definitely mean that something is wrong, but it should prompt you to sort of get evaluated, and because it can be a sign of sort of overall health.
Rachel, this is something that you've said blood pressure a lot. And out of my own ignorance, I suppose, I would think that if your blood pressure is high, then it would be easier to get an erection.
Yeah.
But from what you're telling me, that's seemingly not the case. So what really is the correlation between blood pressure and erectile function?
Yeah. So it's almost counterintuitive how erections work. People think like contraction, muscle contraction, right? You get an erection. It's actually the opposite. The blood vessels are these hollow tubes, right? And in order for them to basically fill, they need to relax. So it's the opposite of what you would think of. So hypertension or high blood pressure is you get a constriction or tightening of the blood vessels, and that's not how erections work. You want the blood vessels to relax so that the spaces in the penis called the sinusoids, they can fill with blood, and that's what causes the engorgement. So hypertension or having high blood pressure is a huge risk factor for erectile dysfunction, and that's because it can impact what we call endothelial function, or like how the lining of the blood vessels reacts to vasoconstrictors, or things that constrict the blood vessels, or vasodilators, and or things that dilate the blood vessels. So your body's constantly in fluctuation between constricting and relaxation, depending on the activity that you're doing. Right? If you're running a marathon, your body is going to try to send blood to organs that you need in that moment. So your major muscle groups in your legs, right? It may not send as much blood to your fingertips because it's not as important in that moment. Or if you're running a marathon, you don't need blood flow to your penis, right? So your blood flow is not really going in that direction. When you're relaxed, when you're with your partner, when you're in the mood, that's when things sort of shift around. It's sort of this constant flux between dilation of blood vessels and constriction of blood vessels. And that's exactly what high blood pressure is. It's an imbalance in those regulators.
Interesting.
That makes sense?
Totally makes sense. I just totally had it backwards.
We kind of talked about it a little bit before, but high blood pressure medications also can cause erectile dysfunction. So it is sort of like a double-edged sword, as you said, right?
Yeah.
It's important that you control your high blood pressure, and I think that's probably a more important contributor in maintaining your erectile dysfunction over your lifetime. But just certain agents you got to be careful of that can cause that at higher rates than others. How
is erectile dysfunction diagnosed? Is there like a legit test for it, or is it just as simple as, hey, it's not doing its thing?
It's mostly just with history taking, talking to your patient. Some important questions I ask are, when did you first notice this? What is the rigidity? Is the problem that you're not lasting long enough, or as long as you'd like to? Is the problem that you are not getting rigid enough? So questions like that, just a careful physical or history. And then physical exam, your doctor may do things like examine the length of the penis, examine if there's any scar tissue that builds up along the shaft of the penis. A testicular exam can be helpful because, if you have smaller testicles, that could be a sign that there's not as much testosterone being produced. So just a careful genital exam. Your provider may also look for things like body hair distribution, because that's mediated by hormones like testosterone. Enlarged breast tissue can be a sign of having high estrogen levels relative to testosterone. So just a careful history and physical exam. There are sort of more advanced testing that can be done in specific populations. They don't necessarily need to be done for everybody. For me personally, we offer something called penile duplex ultrasound. So it's basically just an ultrasound like you would get of your kidneys, like you would get of your bladder. And we can look at the blood flow both in and out of the penis. We can look to see if there's any scar tissue buildup along the penis. But we don't necessarily do that for every patient. And someone who comes in with mild erectile dysfunction, they want to try Viagra, they don't necessarily need an ultrasound. The people I would do an ultrasound on are more like advanced erectile dysfunction. Maybe they're considering something like a penile implant. Maybe they're reporting a bend to the penis, which is sort of another topic on its own called Peyronie's disease. So those are sort of like special, or maybe they are really young with erectile dysfunction, or they had some trauma down in the area. So those are people that we may consider doing ultrasound on. But in general, it doesn't require super specific testing other than a history and physical exam.
And generally speaking, I mean, is there a certain amount of occurrences or a certain amount of frequency in which this needs to occur for it to actually be diagnosed as dysfunction?
Some organizations say that it should be a recurrent problem. I don't necessarily feel that way. Again, you kind of go back to that patient who maybe it happens one time and then, now they have all this performance anxiety and it seems to happen again. So it doesn't necessarily need to be a recurrent problem. I will see by the time most people present, it has been going on for quite some time. It's not the most comfortable topic to talk about with any of your providers, right? So generally speaking, most people I end up seeing, or even primary care doctors end up seeing, it's been going on for a little bit of time, but it doesn't necessarily need to be for it to meet sort of that definition.
And so I'm a patient, I've come in, I've presented with dysfunction. What are some of my options for managing it? Mm-hmm. I mean, from the simple to the complex, what's available?
I think important to note is that we have a lot of treatments. Most of this has come about in the past 40 years or so. Things like Viagra really only came on the market in the early 1990s. So the world of ED treatments is relatively new, but we've made a lot of progress. I think first and foremost, one of the hardest things to do for patients is the lifestyle changes. So there's tons of data showing that certain lifestyle changes can have huge impacts on erectile function. Probably the most important, we kind of touched on this earlier, is tobacco cessation. So if you smoke cigarettes or even chewing tobacco, Zins, all these like vapes, these newer forms of tobacco consumption can all impact erections. And so trying to quit or cut down is really important. There are tons of resources out there. Primary care doctors have resources. There are medications that you can take to try to quit, to help you with quitting. And, that's a huge component. We also know that in men who are overweight or obese, weight loss can have a huge impact on erectile function. And significant improvements, even with a few pounds of weight loss, 5% of your body weight loss can have dramatic effects on erectile function. So that's a really big one. We also know that certain diets, like the Mediterranean diet, has been extensively studied as being better for erectile function. So meaning, I didn't necessarily know what does the Mediterranean diet mean, but things like nuts and legumes and fish and olive oil are better for erectile function than kind of the more traditional Western or American diet that has a lot of saturated fat and trans fats. And so simple dietary changes and weight loss can impact erectile function. Also, exercise. We know that people who get more exercise have better erectile function. And that's probably just a marker, right, of their overall fitness and overall health. But we also know that in people who don't exercise, if you put them on an exercise program, they can show improvements in erectile function. And so, the American Heart Association recommendations for what is considered like optimal exercise. And in general, it's about 150 minutes, which is a lot, but 30 minutes a day of sort of walk, even if it's just walking, should be more like brisk walking. They define it as like moderate intensity exercise. So that can be really beneficial. So those are sort of like the lifestyle changes that can be made. It's really, I feel like so silly saying it to patients sometimes, but anything that's going to improve your health is going to improve your erections. And it's a hard thing to hear, right? No one wants to like exercise every day, and no one wants to not eat hamburgers. And so it's frustrating, but those changes can have a huge impact. Medications are a huge part. I do want to touch for a moment on like over-the-counter medications and diet and like supplements that you can find at Costco or GNC or any of these, or even online. They're not very regulated, and I think that's important. There's really no oversight by the FDA or really any other governing organization as to what goes into those supplements. So some of the more common supplements that you may see are like things like DHEA, L-arginine is a common one, and then Ginseng is like hugely popular. I don't think that these things hurt. I just don't think that they help necessarily. And they can be a huge drain in your pockets. So I tell people all the time, I don't think it's hurting you other than financially, right? Because people sink a lot of money into these things. One important point to make about that is one way that they may harm you is that because they're not very regulated, anything can be in it. And I actually worked on a project looking at the FDA recalls of a lot of these medications on Walmart, on Amazon, on all these online platforms, or even in person at these stores. Things like Viagra or Cialis were actually in those supplements, and they were not disclosed in any way or quantified in any way. So it can be really dangerous for people who are on other things that can interact. For example, men who have a prescription for nitrate. So that's a medication that people can use when they're having chest pain to try to open the blood supply to the heart, because that's usually what's causing their chest pain. If you take a nitrate with Viagra, it can precipitously drop your blood pressure and cause you to pass out. And so the use of phosphodiesterase inhibitors like Viagra and Cialis is contraindicated in patients on nitrates. So you just have to be really careful. Check with your doctor. Tell them what supplements you're on. No one's going to tell you not to take them. I think it's just important that you have sort of an understanding that they are unregulated and there's sort of mixed evidence if they really work. Kind of moving on to other medical options that we have available. So the most commonly used medications for erectile dysfunction are this class of medications called phosphodiesterase inhibitors. So these medications, the generic names are sildenafil, tadalafil, vardenafil. People more commonly know them as sildenafil as Viagra, tadalafil Cialis. Those are probably the two most commonly used ones. Those are pills that you can take. Usually you take them on demand, so about an hour or two, depending on the agent, prior to intercourse. And the way they work is basically to help dilate those blood vessels, to draw blood into the area and help you get an erection. They are very helpful and they're very effective. I think about 70% of men will respond to them, depending on the severity of the erectile dysfunction. But it's really our first line agent. The side effects in general are pretty minimal. People may get a headache, some blurry vision, ringing in the ears, but those are usually self-limited, meaning as the drug clears out of your system, those side effects will go away. So those are really common. There are other medications like injectables into the penis. So they're meds that work very similarly to Viagra and Cialis, but they are used either intraurethral, so like a jelly or a suppository that you put into the urethra where you pee from. And usually you use that about 10 to 15 minutes prior to sex, so they act much faster than the pills. Or injections where a small, very, very small needle, almost like an insulin needle for those who are familiar with that size, are used to inject a medication into the penis, also about 10 to 15 minutes prior to erection. And those medications, like the gels or the injections, generally are much more potent than pills. So it doesn't have to work this way, but most people will start with pills, see if they respond. If they need something stronger, we can move on to sort of those other things. There are patients who just want to go on injectables, and that is totally fine. There's nothing, in our guidelines or anywhere that says that the treatment has to be in like a stepwise approach or you have to fail the less invasive things. It's totally based on whatever the patient wants. So if they had a friend who was on injections, people talk about it, they had a great response, they may come in and ask me for that. And I don't think there's anything wrong with that. Beyond medications, there's surgery. So one of the surgeries I do as an andrologist or a urologist who specializes in sexual medicine is penile implant surgery. So basically, there's a surgery, about 2-hour-long surgery, where a device is inserted into the penis. There's different types of devices. Probably the more common of the two is called an inflatable prosthesis, where essentially the regular spaces that fill with blood during erection are replaced by balloons. And then you have a pump in the scrotum that the patient will access, and they pump fluid from a reservoir that is usually up in their belly somewhere. They pump the fluid from the reservoir into the cylinders that are in the penis. The cylinders expand with the fluid. That's how you get an erection. And then when you're done, you deflate it. So that's kind of the surgical management. And a lot of people have heard about this before they come to see me. A lot of patients haven't. So usually people who haven't heard of that, it seems kind of crazy to start with, but so we start them on kind of less invasive things. And, we're always talking about if this doesn't work, surgery is always an option.
Are there certain medications or any programs, therapies, we'll get into the therapies here in a minute, that could be dangerous when treating erectile dysfunction?
Yeah, I think in general, most of our ED treatments are very safe. With pills, pretty mild side effects. Some men may have some headaches or a sensation of flushing, like their cheeks are getting warm. Some may have some ringing in the ears. Some may have some blurry vision. GERD or like acid reflux symptoms are not uncommon. But they're generally well tolerated. Not everyone has those symptoms. And even the people who do, or side effects, but even the people who do, they're like, oh, I had some heartburn for an hour. It was fine. So those aren't necessarily like dangerous side effects. Probably the most dangerous things, like we touched on a little bit earlier, is making sure you know what other medications patients are on, because using things like Viagra, if combined with certain other medications, can lower the blood pressure significantly and cause people to faint or pass out. So it's just important to know, as long as you're aware of those other medications to kind of be careful of, most of the time those things can be managed. Probably the most looked after side effect as a urologist is something called a priapism, where
a priapism?
Okay. Where it's almost working too well, the treatments. So It's an erection that's lasting for too long, and that can be painful when it's going on for too long. So we generally tell people if it's approaching 4 hours of an erection, they need to seek emergency care. And the only reason it's important, it's not going to kill you, but if you have a prolonged erection, it actually impairs oxygen from getting to the penis if the blood's just trapped in there. So you can actually permanently affect your erectile function even more if you let that erection go on for too long.
Oh, geez. Okay. Priapism?
Priapism.
Now I know the word for that. So is erectile dysfunction something that can be cured?
It's a really good question. I think a lot of the treatments that we have now, or most of the treatments we have now, are not necessarily reversing the process that's causing it, right? We talked a little bit about some things that can impact erections, like having poor blood supply to the area for, example, because of having high cholesterol, where you have like plaque buildup in the blood vessels. Now, giving someone Viagra is not going to reverse that process, right? What's going to reverse that process is working with your primary care doctor to take things like a statin or things that are going to reverse or help having high cholesterol. So, the treatments that we have for erectile dysfunction are not necessarily curing it or reversing that process, but rather almost trying to overcome whatever process is impairing the blood flow into the area. So if you have diabetes and the nerves to your penis aren't working as well as they once did, that's the erection is mediated by a neurotransmitter called nitric oxide that the nerves release. And so what Viagra does is it acts on the downstream pathway of the nitric oxide so that you don't need to release as much nitric oxide. So it's kind of skirting around the problem rather than reversing it. But it is a really important question that I think a lot of people are asking, both patients and also providers, because there is a ton of research now about this field of ED treatment called regenerative therapy or rejuvenative therapy, where the goal is not necessarily just to treat the signs like our treatments do now, but rather try to reverse the process. So, some commonly referred to treatment modalities now are, a huge one is called shockwave therapy, where basically an ultrasound is applied to the penis and it releases sound waves that sort of try to disrupt the blood vessels down in the penis. And when you disrupt the blood vessels, it sounds counterintuitive, but it actually promotes stem cells or immature stem cells that can then rejuvenate into healthier cells. It recruits those cells into the area. It recruits growth factors, which promote, healthy growth of tissue into the area. So the goal is basically to try to restore healthy tissue rather than just, treat the signs of the erectile dysfunction. Some other things that are in the works are things like injections into the penis of either stem cells, like I alluded to with the shockwave, or something called platelet-rich plasma, or the P shot, where basically they get plasma from your own blood that they filter out your blood and then they condense it down to what's called platelet-rich plasma. So it's a component of your blood that's very dense in these, growth factors, and then they inject it back into the penis to try to promote that rejuvenative process. I think important to know is all of those things are what we now consider investigational. So there is some evidence that those things work. There's some evidence that they don't work. I think our data is just not robust enough yet for them to be considered, mainstream therapy. They are available in the community. A lot of these centers will have advertisements for shockwave therapy, and I don't necessarily think it hurts. It can be quite financially, it can be very expensive. And so, it's just something to weigh if you are a person seeking out those treatments that, currently the data is not quite there yet. I don't think we're far off, but it's just at this point, the Sexual Medicine Society of North America, or the SMSNA, it's like one of our major governing organizations with sex med, they still consider these things to be investigational and should be only really performed if part of a clinical trial.
So there was something before we jumped on camera, we were chatting a little bit, and I had never heard of shockwave therapy before, but there's something that was really interesting that you told me that I think a lot of people in the audience need to know, and that is that there are different types of, I just hit the microphone. There are different types of shockwave therapy, and not all of them are the same.
Right. So, the legitimate form of shockwave therapy that actually may work is something called linear shockwave therapy. That's in contrast to something called radial shockwave therapy. And it's kind of self-explanatory. Linear shockwave therapy is basically an ultrasound probe is applied to the penis, and the sound waves or shock waves are directed linearly, so focally on one point, and they can penetrate into tissue at a deeper level. Radial shockwave therapy, in contrast, is dispersed waves that are dispersed over a wider surface area, and they don't penetrate tissues very deeply. And so radial shockwave, and the difference, an important difference is that the radial shockwave therapy is not at the same level of FDA approval as the linear shockwave therapy, and you don't need a doctor or really any trained medical personnel to perform the radial shockwave.
You can just be anybody with a device.
You can be anybody with a device. You can even be yourself. You can find these devices online. And I think an important distinction is that the radial shockwave therapy, there is no evidence that works. You got to be careful. There's companies, they will market themselves as being able to treat erectile function. it doesn't work. And, just you really have to know ask your provider, because you just don't know what is being marketed towards you. And there's a lot of like direct to consumer marketing in this space. You'll find these centers like, what we call like med spas or like general wellness centers that will offer radio shockwave therapy. It's not done by a doctor. It's not done by a physician assistant or really any trained medical personnel. And so you just have to be careful. The linear shockwave therapy, there are legitimate centers that are offering this. Again, it's a little dicey because we don't necessarily know yet the optimal like protocol for these things. So there are some studies that show like they got a treatment at 3 months, 6 months, and 12 months. We don't know long term. Is that something you need to continue? We just don't have the longitudinal data yet. I think one day we will. We just at this point don't have all the data we need to kind of guide patients a little bit better. But yeah, definitely linear versus radial shockwave therapy is a hugely important distinction.
Rachel, are there any at-home therapies or natural therapies or medicines or something like that I can take in order to reverse or manage my erectile dysfunction?
So I think over-the-counter supplements or nutraceuticals or these herbal medications, you hear them a lot on the internet. You see them at stores like GNC. You even see them at Costco. They have a whole section for men's health now. And there's a lot of direct-to-consumer marketing that happens in this space because people really just want to try everything. They may be reluctant to, take prescribed medications. They may be reluctant to talk to a provider even to get the prescriptions. So they want to try things first at home. Some common over-the-counter supplements that are used are things like DHEA, L-arginine, nitric oxide. You'll see as a substance. It's a neurotransmitter that naturally occurs, but they'll sell it to you. Or things like ginseng weed. Those are kind of the more popular ones I hear patients talking about. And I think the data to support their use is very mixed at this point. They're not very robust studies in terms of like the patient recruitment into the studies. They don't follow them necessarily over long enough periods of time to see the long-term effects. There's just not enough data to support their use one way or another. I don't think that they hurt necessarily, with the caveat of you have to be very careful in terms of what may be in those things that they're selling you that may not be listed or it's in the fine print, because they're not really regulated at a like FDA level or professional organization level. There's no oversight into what goes into them. So, for example, there may be unlabeled Viagra or sildenafil in this supplement that they'll market it as like men's max boost like supplement. They come up with all these names, and there may be hidden prescription medications in there that they don't tell you about. And for example, for someone who has a prescription for a nitrate, that meant that a person may be prescribed for chest pain. That's strictly contraindicated to be used with something like Viagra. And so knowing what's in those supplements is really important.
That's crazy that they could do that. It seems like that would be highly illegal.
Yeah, they have very careful marketing about what they can promise from that medication. So if you look carefully, they'll never promise that they can cure or improve a disease. So there's subtle wording that they find that they can kind of get away with it.
I would have to imagine, though, that given the fact that a lot of individuals who are experiencing erectile dysfunction, it is anxiety or something like that. So for a lot of people that go out and they get ginseng weed or something like that, it might just be the placebo effect,
sure.
that they're like, all right, I'm ready to go now. And they're firing on all the cylinders. Whereas before they just needed something to push them over the...
Yeah. No, definitely. And I don't overlook the importance of that, right? Like I see young men, like 18-year-olds who have some degree of erectile dysfunction. And it is often related to performance anxiety. And if you give them like a month of Cialis, it's not necessarily that they have a blood flow problem or they have a nerve supply problem to the area, but they do have a psychological input problem. And so sometimes just getting them an erection like a few times, they'll suddenly get their confidence back. And so they don't necessarily have to stay on that medication forever. It's just getting that confidence back, overcoming that performance anxiety. So yeah, I do think that placebo does play like a huge role in some patients, right, who have ED, particularly in patients with what we call psychogenic ED or some psychological input that's causing it.
Are there illnesses in which erectile dysfunction? I mean, we've covered some of it, but are there illnesses that erectile dysfunction can be expected?
I wouldn't necessarily use the word expected, but I think for sure more common. Anything that impacts the blood supply to the penis is going to potentially affect erectile function. So patients with cardiovascular disease, patients who have had a heart attack, patients who have high cholesterol, patients who have high blood pressure, those are all disease states that can impact erectile function. We do know that men who have something called metabolic syndrome, which is sort of this constellation of obesity, insulin resistance, diabetics, they definitely have higher rates of erectile dysfunction when compared to normal controls. And we did touch on it a little bit, but obesity itself is sort of characterized by having a lot of oxidative stress in the body. So free radical production, release of inflammatory markers just from being obese or being overweight. And that can, in fact, affect the endothelial function or how the blood vessels relax or constrict. So it's really common in men with metabolic syndrome. Also really common in men who are smokers who generally also have those things like can have those things like cardiovascular disease or obesity because, smoking can have a lot of different effects. Another important group to think about is those with abnormal nerve function. So anything that can affect the nervous system at a central level, meaning brain, spinal cord, or the peripheral nerves and the nerves that go out to your arms and your legs. And so patients with spinal cord injury, and that's a huge part of our veteran population, unfortunately, spinal cord injury patients will almost always have some impact on their erectile function depending on the level of their spinal cord injury. Diabetics, erectile dysfunction is very prevalent in diabetic patients because there is an impact on how their peripheral nerves work. And then, a really important group to think about is people after surgery. So there are definitely a lot of surgeries, particularly surgeries down in the pelvis. And for me as a urologist, that's most commonly like a radical prostatectomy or surgery we do to remove the prostate for prostate cancer, or radical cystectomy where we remove the bladder and the prostate, and that's usually for bladder cancer. Almost all men after those surgeries will have some degree of erectile dysfunction. It may recover to a degree, but I like to see those patients really early on after their surgeries because there are things that we can do to kind of get things to come back a little bit faster or come back at all. So those, neurologic conditions can be very associated with erectile dysfunction. Those with metabolic abnormalities can also have ED. So, we touched on this a little bit earlier, but any condition that can be associated with low testosterone can be also associated with not only erectile dysfunction, but sexual dysfunction in general, sex drive or libido, the ability to get achieve orgasm or to ejaculate can all be linked to having low testosterone. And, some men, that means they just have low testosterone. Their testicles are not making enough testosterone for one reason or another. But for some men, that may be because of a thyroid condition or because of a brain condition where they're releasing too much of something called prolactin. So, that's why it's always really important to get checked out and not just, assume that it's because of one thing or another, because ED can be associated with so many different conditions.
Yeah, so that's one of the things that I want to cover with you is, having erectile dysfunction itself may not be deadly, but
Correct.
There could be some underlying condition that could prove deadly.
Right.
If I'm displaying signs or symptoms of erectile dysfunction, go see a doctor. Don't just try to take something from Costco and deal with it on my own.
I think that's true. If you see a primary care doctor and you're regularly like being assessed for your overall health, that is typically sufficient. This doesn't mean that you necessarily like need to go see a urologist or specifically like a men's health center for erectile dysfunction. But in general, like making sure that your primary care doctor, making sure that you're seeing a primary care doctor, making sure that you're up to date with sort of like general screenings of health from your primary care doctor can be really important. Of course, there are things that you can try at home also. We alluded to this a little bit earlier, but if you're overweight or you're obese, trying to lose some weight, trying to participate in some cardiovascular exercise, getting out and moving, trying to stay away from substances like alcohol, tobacco, even cocaine, marijuana. These are things, lifestyle changes that you can make on your own, and I encourage you to. But yeah, I think I cannot emphasize that link between erectile dysfunction and cardiovascular disease enough. We know that particularly in younger men, less than the age of 40 or 50 or so, men with ED have a 7 times greater increase of having a cardiovascular event compared to men who do not have ED. So really, don't hesitate to seek out care.
Yeah, it's a crazy stat.
Mm-hmm.
That's pretty serious. Well, Rachel, I thank you so much for coming on the podcast.
Of course.
A lot of great information, and we'll have some links and additional information in the video description below. And as always, thanks for tuning in, and make sure to hit that like button and subscribe. You've got questions and we've got answers. Whether you served, are currently serving, are a caregiver, or a veteran advocate, the SITREP is your trusted source for information. Subscribe today at www.youtube.com/@VA Made Simple.